unfortunately the graft failed and she had very poor visual recovery. The patient in 2010 developed acute eye drops in the right eye, but fortunately had a good visual recovery, and then started developing slow, painless diminution of vision in 2014 and presented to us in 2016. This was the clinical picture of her left eye. This was a clinical picture in the right eye. And as you can see very clearly, there was a scar of the resolved eye drops, an area of thinning, which was off-center, and cataract. The topography showed the size of the scar. At this point of time, there are multiple options. One of them is we do a combined procedure of keratoplasty, lens extraction, and intraocular lens implant, or we do keratoplasty followed by cataract surgery, or third is we simply do cataract surgery without keratoplasty. The patient had a bad experience with keratoplasty and was not very keen on undergoing keratoplasty. Therefore, we decided to go ahead with the cataract surgery alone. The question that came to our mind is what type of intraocular lens are we going to use, and how presence of corneal scar and ectasia is going to modify our decision on the IOL selection. So the objective of my talk will be to discuss with you some of the anatomical facts of ectatic cornea and how these facts pose challenge as far as IOL selection is concerned, and the guidelines in the management of such eyes to get more predictive post-operative refractive outcome. Now you all are aware of that ectatic diseases of cornea are characterized by thinning as well as ectasia that results in irregular topography. There is increased corneal power, but unfortunately that increase is not uniformly distributed through cornea. The ectasia results in increased anterior chamber depth and there also the increased axial length. Now whenever you do keratometry in these eyes, you have to remember that the ratio between anterior and posterior corneal curvature is altered in these eyes with ectasia. The Placido's disc-based corneal topography systems are not very accurate because they scan the front surface of the eye, which does not give you accurate keratometry. And the third is that in the 3 millimeters zone, whatever corneal power you get may not be reflective of the total corneal power that this person has. At times, even the apex of the cone is not central, and this alteration in the location of the cone can affect the overall post-operative outcome. The increased axial length and anterior chamber depth in particular affect the effective lens position that may also alter the post-operative outcome. If you use the standard set of IOL formulae to calculate the intraocular lens power, they usually lead to hyperopic refraction. And therefore, these patients have very unpredictable post-operative refractive outcome. So what are the solutions? What are the strategies that we can use for proper IOL selection? The first and foremost is that you have to ascertain the stability of ectasia. If keratoconus is still progressive, use collagen cross-linking or intrastromal rings to flatten cone. If the keratoconus is advanced, perform corneal procedure before you undertake corneal surgery. Ascertain the severity of ectasia. It is important because you can use measured K value for mild to moderate keratoconus, whereas you must use the standard K value for severe keratoconus. You should also make a note of location and centration of cone because that affect the spherical equivalent as well as cylindrical error that these eyes have. On the keratometry side, you should use Symflug-based imaging devices rather than Placido's-based topographers. And Pentacam usually give the best results on. You must also ensure that you take multiple readings and ensure that these readings are repeatable. As regards different IOL formulae, there are some modifications in the IOL power calculating formulae which are aimed for calculating IOL power for keratoconic eye. If we look at the performance of these IOL formulae, it has been found that the formulae which are modified for keratoconus are the best as far as the post-operative refractive outcomes are concerned. Other formulae, less number of the patients get refractive outcome within half diopter of astigmatism. Now, the other thing that you have to keep in mind, while in stage 1 and stage 2 keratoconus, most of the formulae are very predictable. But when it comes to stage 3 keratoconus, the keratoconic formulae are best, or else you can use SRKT. All other formulae give very poor refractive outcome. You must have a target refraction based on the severity of disease. For stage 2, you should aim for more myopia, roughly about 1 diopter, and in stage 3, about 2 to 3 diopters of myopia. Avoid aspheric IOLs, because these IOLs are aimed at negating the positive spherical aberration. So if you put an aspheric IOL, you will have much higher degree of hyperopia post-operatively. What about toric intraocular lenses? For mild to moderate keratoconus, you get very good outcome from toric intraocular lenses. However, the toric intraocular lenses have to be avoided in progressive disease, where there is a very difficult refraction, and particularly in cases where there is a wide gap between visual acuity as measured with rigid gas permeable lenses and with the spectacles. So to summarize, the intraocular lens selection in ectatic corneal disorders is challenging. We need to be familiar with anatomical facts of such eyes and the guidelines that I just narrated to as far as IOL selection is concerned if you want to achieve the best outcome. The post-operative refractive surprises are common, and therefore it is important that we counsel these patients about the unpredictability that is associated when we operate cataract in these eyes. Thank you very much for your kind attention.
We have a microphone in the audience if anybody would like to come up and ask any questions. To Judd.
Okay, perhaps I just wanted to ask a question. One of the things that I think in some of the more severe cases is whether the patient's wearing contact lens. Because that will, of course, affect your IOL, basically, power as well. Because if you know that they're basically going to go back into a scleral lens or something like that as well, then, of course, that will then allow you to determine your variation, or it will give you a sort of a larger landing zone for the IOL. And I found that it's a lot easier, to be frank, if they're going to wear a lens afterwards, because then you can feel, okay, well, I can be a little bit more liberal with the lens choice that I'm basically going to put in. That's one thing I was going to say. And the other thing is that one of the things, especially in the higher levels, like grade 3 or 4 above, is that because your quality of vision is always impaired, because of course the coma level is still there from the keratoconus, which is not fixable by any basically procedure. On the lower grades, do you combine the treatment to try to treat the aberrations with any laser procedure or after crossing? So what are your thoughts on that?
So what we can do is that you can either intraoperatively perform some of the procedures that are, or post-operatively you can do the refractive correction once you have the outcome of your cataract surgery. I think here I see definite role of light-adjusted intraocular lenses, and once these become commercially available, they are going to be of great help. Currently, one of the investigator in India is working on developing these lenses, and I'm sure that probably in 2025 we will have those lenses available.
Just to comment on the LALs, I would say that LALs, you can only correct up to 3 diopters of astigmatism there and 3 diopters of myopia or hyperopia. And for low levels of keratoconus, I have found you can get some good results. However, I just caution, I mean, the LALs are great. However, I just use caution even with keratoconus there. I think just like with the toric lens, there is some utility. However, it's not the panacea.
Yeah, I agree.
So I was just wondering, for this particular patient, this young woman, what did you choose?
Very good question. I removed those slides. I thought probably I'll be overshooting my time. But we left this girl a phakic. And then with contact lenses, she had 20/20 vision. And she was really happy that she had not to undergo corneal transplant.
Yeah, that was a good question, Audrey. That was one of my questions. So I have had such cases, and I can tell you, I ended up putting like 0 diopter lenses. Just didn't want to leave them aphakic because they're young patients. But in contact lenses, we got them to like close to 20/25. I've never had a patient except stage 1 keratoconus who did not need a contact lens after cataract surgery.
Ah.
They always need contact lenses for a couple of reasons. One, they're used to contact lenses, wearing those. Second, as Joe mentions, the quality of vision actually is better with a contact lens on, unless you're doing a transplant in future, which becomes difficult once you have somebody who's BCVA, kind of contact lens 20/25 or 20/26. I do use Pentacam, EKR values. They're useful. I think Naoyuki Maeda from Japan, he published a large series, and ages ago he basically asked me to use EKRs. I'm still using EKRs at about 4 millimeters. Pentacam gives out that reading, and I've been fortunate. They're usually within 3 diopters, which is good enough for these patients.
Yeah. No, I had one patient where I did DSEC and post-RK cornea. That patient developed endophthalmitis, interface infection. And then I had to do the penetrating keratoplasty, and the patient ended up with -11 myopia. So another challenge that comes in ectatic disorder is if you have to do full thickness graft or other procedure, then you really get a refractive surprise of great magnitude.
Yeah.
Contact lens, yeah. Contact lens.
Right. I will introduce myself again, Tony Aldave. And my topic, if I got my slides up, is related to something that you just heard discussed, the LAL and its potential utility at the time of combined endothelial keratoplasty and cataract extraction. By way of disclosure, I have no financial interests relevant to this presentation. So I want to present to you a patient who I saw. This is a recent case, 67-year-old woman who presented with slowly progressive decrease in vision in her left eye for the last several years. She'd had LASIK performed in each eye in the late 1990s, dry eye syndrome, Fuchs dystrophy diagnosed a couple of years ago, and nucleosclerotic cataract in each eye. On exam, vision in the right eye was not bad at 20/25, but fairly poor vision in the left eye at 21/25. You see her refractive error listed there. See also the central corneal thickness, a fairly edematous cornea in the left eye. In the right eye, on slow lamp examination, 1+ central stromal edema and 1 to 2+ nucleosclerotic cataract. Left eye looks similar with a LASIK flap, but she had central epithelial edema in the left eye. That was probably the reason why her vision was so poor. A little bit more stromal edema, and again, a 1 to 2+ nucleosclerotic cataract. So I did tomography for this patient. This is the right eye. Again, she's had prior LASIK surgery. You see her mean K value is 44.0. In the left eye, the mean K is fairly similar at 43.6, but you can see on the axial map a very irregular cornea with a focus of scarring or flattening, something here, and relative steepening superiorly. So a fairly irregular cornea, although the mean keratometry value is fairly similar to that in the contralateral eye. So what do you do when you have a patient for whom you're going to want to perform endothelial keratoplasty, either DMEC or DSEC, plus cataract surgery, who has epithelial edema in the operative eye that prevents you from getting accurate keratometry? You can either say, well, yeah, like in this case, the K value is about the same as the other eye, so I'm just going to use it, even though that's a two-toned cornea. You can, if you're smart, go back to keratometry that was performed prior to the onset of epithelioma. And every time I see a patient with Fuchs in my practice, we always get baseline tomography, so we'll know what their Ks are if they do develop epithelioma in the future. You can do a debridement and then measure, and we've done a small study looking at keratometry values post-DMAC compared to doing keratometry on exposed Bowman's layer, and it's, as you would guess, about the same, not a big difference. Or you can use K values from the contralateral eye. So these are your options in this situation. Again, remember, this patient's had prior LASIK surgery, so you also need to account for that. Everybody has their preferred formulas or techniques for adjusting IOL power calcs in patients with prior refractive surgery. In this case, I usually use the ASCRS post-refractive IOL calculator and the Barrett TrueK, which is in the ASCRS, but I also use it separately as well. So the calcs, as you see here, that came up for we're using the ASRS post-refractive IOL calculator range between about 19.6 and 22, depending whether I'm using Ks from the right or the left eye. The Barrett TrueK formulas between 21 and 22, again, depending on whether I'm using Ks from the right or left eye. And if I just ignore the fact she's had prior cataractive surgery, just use IOL master calcs, you see between 20.5 and 21. So I decided to sort of split the difference between the highs and lows, the range from the ASRS calculator as well as the Barrett TrueK, and went with the 21.5. So I performed surgery for her in May of last year, put in SN60 WS plus WF plus 21.5. Surgery went fine, but you'll note that 3 months after surgery, the patient was not happy with her uncorrected vision. She corrects to 20/40, but with about plus 2.5 diopters focal equivalent refractive error. Checked her again a couple months later. Now she corrected down to 20/25, but now with over 3 diopters of hyperopic refractive error. Again, not my happiest patient. And then in January of this year, she corrects finally to 20/20, but with a focal equivalent refractive error of more than +2. And again, I aim for -1. So we had a greater than 3 diopter hyperopic surprise. Why is that? I went back and checked all my calculations. They were done correctly. Well, here's the patient's left eye. This is in October, so we are here about 5 months post-op. You can see that that mean K value is 40.0. Remember, pre-op, it was 43.6. The other eye was 44. So this eye is 4 diopters flatter than the contralateral eye. I said, well, it's going to hopefully steepen over time. It did a tiny bit, but only to 40.6. So here the problem is, and you can see on the axial map, we have a much flatter cornea, and due probably to the subtle subepithelial scarring that she has that was a result of the epithelial edema. I looked very carefully pre-op, I always do for subepithelial scarring, but you guys know if the pachymetry is 800 and something and you have epithelial edema, it's very hard to determine if there's any subepithelial scarring there, and if so, how much. So how common is this? This paper from Frank Price's group looked at DMAC and cataract surgery with implantation of a monofocal IOL, and they found that only 30% of patients were within half a diopter of the targeted refractive error, and only 50% were within 1 diopter of the targeted refractive error. I think as a lot of us are doing more and more DMAC, we're expecting better and better visual outcomes, that this has become one of the major problems in my practice, is these unexpected refractive surprises after combined DMAC and cataract surgery. And is there some other way to address this problem? Well, per the last discussion we had after the last presentation, yes. One approach is the light adjustable lens. And I think many of you are familiar with this lens. This is a lens that is implanted. You see a 3-piece lens. It's then exposed to ultraviolet light in a pattern such that induces a change in the shape of the lens to correct for a refractive error that is present, as far as corrects both hyperopia and myopia, and as Audrey said, I think up to 3 diopters of cylinder. Once that lens shape is what is desired, is then quote unquote locked in so that the shape is stable. And this is, I think, something that could be of great utility to us as corneal surgeons, keeping in mind, though, that we don't really know the final refractive error after DMAC until you're at least 2 or 3 months post-op. And if you do this combined with penetrating keratoplasty or DALK, you're going to have to wait many, many more months. And so there are some adaptations to the lens that allow for delayed locking in. And Audrey can talk to us about the lenses that patients wear, UV protection to prevent environmental lock-in before it's time. This is the machine. We have this at Stein Eye Institute, and I do not have any experience yet. But after putting this talk together, I decided this is something I'm going to start doing routinely for my DMAC cataract patients who can afford this option. The question is, though, does it improve outcomes? Is this a theoretical advantage, or is there actually any evidence to say that this does improve refractive outcomes? Marianne Price kindly shared this article with me, which is in this month's JCRS, just published, where they looked at Frank's series of patients with DMAC cataract surgery with the light adjustable lens. In 27 eyes, we see that 81% were within a half a diopter of the targeted refractive error. Remember, their prior publication, same surgeon, with a monofocal lens was 30%. And they have 93% within 1 diopter. Again, with the prior series, it was only 50%. So pretty impressive. Also, if you look at refractive cylinder accuracy, they're reporting 93% are within a half a diopter of the targeted correction, and 96% within 1 diopter. So again, it's not the biggest series, but I think big enough to convince me that this is something which can be of great utility in some of our patients. So while cataract extraction is commonly performed at the time of DMAC and DSAC, accuracy of the calculations can be affected by a number of different factors. This patient had a couple of them: prior refractive surgery and corneal epithelial edema, as well as subepithelial scarring, which I didn't appreciate really pre-op. Also, even if the patient doesn't have epithelial edema, we all know that patients with Fuchs, for example, have typically central edema, stromal edema, that can cause a contour change. And once that edema resolves, then the cornea then becomes flatter. So I think that's one of the common sources of error in our IOL calcs in patients undergoing DMAC cataract surgery with Fuchs. So the accuracy of refractive outcomes in patients with corneal edema can be improved. You can do DMAC or DSAC prior to cataract surgery, and I've done this a few times. I know some surgeons do this fairly routinely. In the setting of corneal epithelial edema, using K values obtained prior to the onset of epithelial edema, again, that's useful if they don't have subepithelial scarring, but they do develop subepithelial scarring, those prior K values are not going to be that useful. You can do a debridement. If I do a debridement, I like to usually do it the day of the surgery, because if you do it a day prior or a few days prior, you're going to have increased edema, of course. If you do it maybe a week prior, patients are not going to be happy with the discomfort, so usually do it day of if I do. Or you can use the case from the contralateral eye, but I think the LAL, the light adjustable lens, offers a potential great option for these patients. And I thank you very much for your attention. Any questions or experience with the LAL from those in the audience?
Tony, I agree. I really like the LAL in this situation. I just started to do them for DMAC, and it works very, very well, just for all of the reasons that you delineated. I wouldn't necessarily recommend it for PK, but in the DMAC and DSEC series, you have to be sure that the patient understands that there's going to be several light adjustments. It is a little bit labor-intensive, the post-op, but I actually have my optometrist doing the light adjustments, and that's a big time saver, because it's sort of like it's several visits, 3 to 5 visits, or actually 4 to 6 visits post-operatively. You've got 4 shots on goal to be able to correct the lens, usually within 2 light treatments. It's where you want to be, and then there's 2 small lock-ins. But yeah, I completely agree.
The question I have, and this is a silly question, but I think, you said, what's your second biggest issue you face with doing DMAC cataract surgery? For me, it's IOLs that want to prolapse out of the bag while I'm trying to insert my DMAC graft. That's still, even if I have a decent-sized rexus, say 4.5, and it's centered, I still have trouble sometimes getting that DMAC scroll in. So do you have any thoughts about whether this 3-piece design versus the typical 1-piece that we use, does that make the IOL tend to prolapse more, less, or does not seem to make a difference when you're inserting your DMAC scroll?
I haven't found that it's been a real issue. I also use a femto laser for my capsulotomy in these cases, and when I'm doing my LALs, and I find that that's also very helpful for getting it spot on. I do make it a little bit smaller.
How big?
I do about between I program the laser for 4.8. And so I get about a 5 there. And I find that the lenses center really well. You have to be careful about your capsular polishing, because you can get early fibrosis and need to do an earlier YAG with the lasers. But I mean, with the LALs, it's not that big a deal, but it's nice if you don't have to do it. I did have one case where the patient was having some discomfort, a wiggly patient, and so I didn't polish as I normally do, and she ended up with some fibrosis there early. The lens actually shifted a little bit, and I had to go, what I did is I went back in and then I prolapsed the optic out of the bag. The nice thing is that it's a 3-piece lens, so you can also use it. I've also used it for unhappy patients after a multifocal or EDOF lens. I've done an IOL exchange for the LAL, and you can put it in the sulcus with optic capture, and that works well too.
Huh. Points, thank you. Sunal?
Great talk, Tony, as always. Two questions. One is actually with the prolapse. Do you constrict the pupil before you put the?
Always.
Okay, and it still prolapses out? Because my
Well, it doesn't prolapse out. It's just you get positive pressure. I just find that, sometimes pupils don't come down. Sometimes they kind of halfway come down. But even with a lens in the bag, centered, good rexus, pupil constricted to 4, let's say, I still find on some eyes I'm trying to insert the DMEC scroll, maybe 1 out of 4, and chamber just keeps shallowing.
Yeah.
And the incision's not leaking. It's just the lens is not fibrosed in the bag, and I find
it
that
is
to
definitely
be
much more floppy, right?
Yeah,
at that
and
point.
in fact, when I'm teaching fellows and I teach DMEC internationally, I usually tell them don't do DMEC cataracts until you've done at least 20 DMEC. Do your cataract surgery first and go back into your DMEC a month or 2 later once the lens is fibrosed in the bag a bit, so you don't have to deal with that tendency for the chamber to shallow where you're trying to insert the DMEC scroll.
So my question actually was that, percentage-wise, how many would you say you do together versus do the DMEC first and then do the IOL after, or do the cataract first and then the DMEC later? And in relation to that, how comfortable are you putting a multifocal lens in these patients?
I'd say if I know the patient's going to need DMEC and cataract surgery, 95% are combined.
Mine are too, so okay.
If the view is just really bad, I may do, and they need cataract surgery, I'll do the DMEC first, then cataract later. Obviously, we have these patients with mild corneal edema where I try to get away with the cataract surgery first and then DMEC later if necessary. But in those, I know we're going to need both. It's almost always combined or rarely DMEC first. Multifocal, I haven't.
Okay, I haven't either.
Had,
I'm just curious to.
Yeah, I'm just not sure about the optics. I'm sure many do that, especially in Los Angeles. But I've seen a fair number of unhappy multifocal patients who have Fuchs or had DMEC from other places, and I just don't want to have an unhappy patient with a well-done surgery. John.
Tony, great talk. The prolapse issue is the insertion technique. If you do endo in, you won't get that. Because Divya asked me when she came to Singapore, how many cases do you do mixed? And I do all my combined cases. But I've never had that issue because the AC is completely deep when we pull the graft in. It's a technique issue because when you're doing endo out, you're shallowing the AC. And that's why in those cases, so obviously we get a lot of pseudophakic cases sent to us. And I'm very careful in those cases because if you shallow the AC, vitreous is going to come from somewhere because obviously you don't know who's done the cataract surgery, right? And by definition, it must have been difficult because they've got pseudophakic bullous keratopathy. But with endo in, you avoid all that situation because you're not shallowing.
And the technique you're using is a forceps-assisted insertion?
Exactly. So Divya's video that she basically showed you.
Showed yesterday?
Yeah, so basically just endo in, obviously we use the endoglide 27-gauge forceps and pull it in. You'll never get that because your AC is going to be super deep when you basically pull it in. So you avoid all these issues of shallowing. And when I switched techniques about 7 years ago, I noticed a few cases, sometimes, especially with thick irises, sometimes you see a little bit of pigment release when I was tapping to open the graft. And I just never see that now. And it was just a technique change.
Huh. And probably less CME as well, if you're having less shallowing and less iris manipulation. That's been an issue for me.
Yeah, we discussed some of this stuff that we wanted to discuss, but that's great. One thing about LALs in that paper from Frank, would you guys think that it'll probably, if I have to do an LAL at least for the first 20 cases, I'll probably not do a triple and do a staged procedure So you figure out, the graft is okay, 3 months later you can do an LAL. Or you'd rather prefer a triple if you're doing an LAL. I don't know how difficult the adjustments are. If you have 4 shots at adjusting the lens power, when do you start adjusting the lens power, Audrey? Yeah.
You can start as early as 2.5 weeks, but with DMEC, following a DMEC, I actually wait a full 6 weeks.
6 weeks.
6 to 8 weeks, and I let them know that they're going to have to wear their glasses for 6 to 8 weeks before doing the first adjustment. Normally, if you have a LAL, you can do 2.5 to 3 weeks. If things look stable, you can start the first adjustment then, and then the second one about a week later. Then you can lock in about a week after that, or whenever you want, if it's fine. But with a DMEC situation, I wait a full 6 to 8 weeks because you want it to be more stable. You don't want to do it at 2 to 3 weeks.
So I think that's important as well, the difference. Okay. Well, thank you. Great discussion. So, we're going to take it further. We're going to discuss triple versus staged EK. Let's, revisit the debate. Clearly hasn't been answered. So clearly there's no consensus on whether to stage or combine EK with cataract surgery in patients who present with cataracts and Fuchs or Bullous-Gay. This is sort of roughly what we have in clinical practice. You basically try and distinguish the causes of visual loss, cataract, FECD, or both. If you have significant Fuchs with no cataract, you go for EK alone, if you have mild FECD with no edema and significant cataract, you can basically do a careful cataract surgery because the patient might not need an EK. Or if the edema can be hard to detect, we'll revisit that in a bit. And if you have significant edema with significant cataract, of course, the answer is clear, but we still have to figure out whether you want to do a staged or a combined procedure. This study was published about 10 years ago, really, by the Price Group. They compared 292 pseudophakic DMECs to 200 DMECs, triple cases, and there was no difference in post-op vision, endothelial cell loss, it keeps moving, complications at 3 to 6 months. So clearly showing us the path 10 years ago that triple is the way to go if it's possible. Another study published in 2020, small case numbers, actually found the endothelial cell loss at 1 year was significantly lower at 33% in pseudophakic DMEC versus 40% if you combine. Funny though, because the rebubbling rates were really low and they were comparable between two groups. So when I read the paper, I couldn't really find a reason why would there be a difference in endothelial cell loss. And here's what the actual paper says, that you have greater anterior segment manipulation and post-op inflammation after combined surgery. That might explain significantly higher endothelial cell loss in triple compared to the DMEC-only group, although the paper did not show a higher incidence of cystoid macular edema in one group compared to the other. So we really still don't know. Marcus and Joe published this meta-analysis in Frontiers recently, basically looking at more than 11,000 eyes. They were included in this review, non-comparative, showing that DMEC has a similar post-op complication rate compared to triple DMEC, although the quality of evidence was low at 6 months post-operatively. Again, sort of, a little bit biased towards doing triple whenever possible. Vito published his meta-analysis looking at 5 non-randomized studies, low quality though, again showing that there's no evidence that there's a difference between both groups, triple or staged, in terms of rebubbling and primary graft failure. Sorry, my slides keep jumping. They did say, however, there's a need for randomized control trials to basically answer this definitively. So, just looking at some of the factors that we'll consider, the next few slides is basically represent collective wisdom of some of the physicians that I've spoken with over the past few weeks. We definitely look at patient's age, and it's been discussed earlier in Dr. Aldave's talk as well. You tend to preserve accommodation. There's no cutoff for age, but if you look at all the meta-analysis and all, small and large series, 50 is usually the cutoff point. You do reduce the risk of complications when you're doing staged procedure associated with cataract surgery in young patients, and there's no doubt that most of these younger patients, they're quite fit for those extra anesthesia, extra trip to the OR and hospital visits, although you don't want to do that. Severity of endothelial dystrophy, of course, there's a limited view for cataract surgery. All of us have sort of started the triple procedure and realized in like 20 seconds, oh my goodness, this view is quite different from what it looked on slit lamp. And of course, we've discussed in detail the challenges in IOL power calculation. And from time to time, you keep on getting these patients who end up with the hyperopic surprise. Even if it's +1, patients are clearly unhappy. Patient preference is a big deal, but I have seen, at least in some practices, even here in India, it is very important, but it really likely depends on how they are made to perceive it. So there are physicians in our own group who will say, well, stage is the way to go. And there are physicians in the same group who will say, well, I only do triples. So it's funny if a patient comes back to you and says, well, I met that person and you work in the same department. You're basically saying completely opposite things. Some patients do demand emetropia, even if they have to use reading glasses. And you really have to figure out that you always have to tell the patient, if you have early fuchs, and you're looking at somebody at 65 with corneal thickness of 500 something, they might never need an EK, depending on how bad the fuchs is. This study basically looked at 86 eyes with DMEC triple. This is from Wilmer. Our own friend Divya published this. The mean error refractive error ranged from -0.1 with plus 0.9 with using Barrett's. So they tried to aim for -1. So you got to counsel the patients for refractive inaccuracy when you're doing combined procedure. Financial factors. Not really discussed in the United States many times, but this is real data. Medicare claims analysis, again from Wilmer, more than 700,000 eyes with Fuchs dystrophy. 4.7% received keratoplasty, at least in this cohort, and only 2.4% of eyes with cataract surgery actually received EK in this analysis. So it is not a bad idea sometimes to sort of offer only cataract in such patients. Again, conflicting evidence. Practice referral patterns, very important, no matter where you are, unless you're in a very small, sort of city or town where you're probably the main provider, and, it depends on what kind of patients you see, what are their outcomes, what are they being referred for. Also depends a lot on not only on surgical expertise and experience of the surgeon, but also the surgical technique. All of us sitting here probably have a slight nuance about doing EKs, technique, how you rebubble, how you bubble, whether you use 100% air, whether you use SF6 and all that stuff. There's a lot of variation there. I want to revisit this quickly. In cases where it's hard to detect subclinical edema, we have sort of tried to use Sanjay Patel's formula for looking at the pentacam. We all know that there are 4 signs in pentacam: displacement of thinnest point of cornea, loss of parallel isopax, sorry, 3, and focal area of posterior surface depression. So if you look at this sort of protocol that has been published in ophthalmology, if you have Fuchs with subclinical edema and your patient shows features of corneal edema, frequently over 3 or typically at least 2, you can basically, well, you can't be sure, but you can basically tell the patient accordingly that you might need EK at a later stage, and it might help you to a certain extent to make a clinical decision. EK first, of course, you can stage it in a way where this EK first, we've discussed this briefly. Sometimes this is a difficult decision, not in very young patients, though. It improves the accuracy of IOL power calculations. I think that's one of the most important advantages of doing EK first, and it facilitates the placement of toric IOL or a presbyocorrecting IOL or even LALs. There's always an inherent risk of graft attachment and endothelial cell loss, and eventually leading to failure. So important to tell the patient, inform them properly before you go ahead. This is a paper basically from Melly's group, looking at phakic and pseudophakic eyes with Fuchs. They had similar BCVA and endothelial cell loss and rebubbling at 6 months. 17% of cataract surgery rate in phakic DMEC at 5 years. So EK first might be preferable for young patients with residual accommodation, as we discussed earlier. Previous paper from Price's group, stage procedure with EK first, had 16 eyes that received premium IOLs, and all patients had actually good results, 2025 with distance, acuity, and near was 2020. So just to conclude, well, I hope these are the conclusions. Young patients, you can do stage with EK first. We have early EK cases. You can use those parameters on Pentacam. You can do stage with cataract first. Surgeon experience, well, it depends. I always look at, if you speak with someone and say, well, I'm experienced enough to do a triple procedure, I won't have any issues. And somebody else might say, well, I'm experienced enough to do an EK first and then take care of my patients in a better way, giving them 20/20 or 20/15 vision. Patient preference, as I said, it really depends on how you are leading the discussion. Stage can be as good as triple. And financial considerations, definitely, as Tony said earlier, 95 to almost 100% of my patients who are more than 60 or so have some cataract, I'll go ahead and offer them triple instead of stage because of financial considerations as well. Thank you very much for your attention.
Very nice presentation. I want to give you a hypothetical patient and see how you'd manage this patient. Let's say somebody who's 60 years old, central corneal pachymetry 600, no epithelial edema, no stromal edema visible on exam, but on Pentacam imaging has displacement at the thinnest point, has loss of parallel isopax, and has posterior displacement of the posterior corneal profile. And is not happy with their vision. Do you do cataract surgery alone, or do you do cataract surgery with DMEC in that patient? Or what other factors like cell count, posterior corneal fibrosis, what other things go into that decision-making process?
Yeah. Am I practicing in India? I'm just joking.
Let's do in India first and then in Pittsburgh second.
No. So the short answer is I'll offer triple, like straightforward answer. 60 years old, has some cataract. Eventually they would need cataract. So it's a really straightforward answer.
But why do the graft if there's no stromal edema evident on exam?
So I was going to come to that. So
okay.
I do look at the amount of goutte, the density in the center, the quality of vision, night vision. So there are patients in my practice who present with 20/30, 20/25 with grade 1 to grade 2 nuclear sclerosis and Fuchs dystrophy. You do basically a triple procedure, they end up at the same level, 20/25, 20/30, a lot happier because the visual quality improves a lot. Something that I didn't mention, and I've sort of started collecting data only since last year, I do look at the family history as well. I ask them, when did your mother need transplant surgery, and how strong is the family history? How many people had transplants? And this is not going back 30 years when everyone was doing PKs and stuff for Fuchs, or people were getting pseudophakic bullous when Fuchs was undetected and they had cataract surgery in a bad way. So I do consider that as well, to a certain extent. But I think quality of vision is important for my patient as well. I mean, clearly, we are not there yet in terms of evaluating these patients, I think, preoperatively. Joe did publish a paper some time ago where you were looking at quantification of goutte, just looking at the slit lamp pictures. I think we do that in clinical practice, although we are unable to quantify those, but you can basically see how the goutte are basically, how dense they are, and are they widespread or not. So.
Do you use a microphone?
So what we're doing now is, and we just finishing off paper on this now, is that we're looking actually at, to answer Tony's question, because I see a lot of patients sometimes that have, they may have slight abnormality on posterior photo, like Sanjay basically showed. Actually, some have no abnormality, but they have this fibrotic scar on Decimate. So we're actually now using densitometry, because I realized from that paper that the problem is that we have a very good photographer. And when I asked them, lots of people started sending me images saying, John, can you quantify it? But the quality was so poor. I was like, okay, this is not going to be practical. So then we thought, okay, is there another way we can look at this? And actually what we're doing now is on the Pentacam, you can put up densitometry, and you can adjust your posterior densitometry to be about, so it's preset, I think at 60 microns from the back at 120 at the front. And you can adjust the posterior one to be 30 microns away from Decimate's membrane. It's just a scale bar. It's very simple to do. And that actually gives you a very good idea of basically backscatter for the patients as well. And if they have high levels of densitometry abnormality, then I will do basically a triple as opposed to basically doing a primary procedure. And I noticed there were a lot of patients that didn't have an abnormal posterior flow but had high levels of densitometry scarring. And that basically affects my decision making.
Huh. And how do you make that adjustment? Just go in the pentacam and just adjust from posterior 60 to posterior 30?
So you just put up the densitometry screen on the pentagram, and there's an automatic set of like 120 from the front, 60 on the back, and you just basically push the scale bar down to, you can just say put it in at 30, or I chose 30 as an arbitrary figure, and we basically put 30, and then we compared 30 to 60 values as well. And I just used 30. 30 is pretty accurate, and it will really give you a good idea. Then suddenly you'll see the screen will change, and then if you put the cursor over the densitometry map, it will tell you the actual value from there itself.
So you can get the mean value in the zones as well, 3 zones. So.
Right. Good tip, thank you.
I just want to extend the question that you asked. If the first eye has developed, say, the steroid-induced glaucoma and extensive disc damage, will you still do the cataract surgery alone, or will you do the triple procedure?
Sorry, what? I didn't hear you, Prashant. Sorry.
Suppose this is the second eye, and the first eye had steroid-induced glaucoma with...
So you did the first eye.
He wants to know if you're going to do a DSO instead.
You did the first eye, huh? Yeah. No. Yeah, I don't think that's gonna impact my decision if the patient has steroid-induced glaucoma in the first eye. I mean, that's a whole lot different discussion of why the patient developed that and how quickly you taper off the steroids.
But wouldn't that push you towards thinking about a DSO? Thinking I'd like to address their Fuchs without the need for long-term steroids?
Of course, it depends where the good hair are. I'm not a big fan of DSO, I have to say that. So it would not...
Does your partner know this? We're going to tell Deep.
Does your work partner know that? So, yeah, not a big fan of DS. So I'd rather put a thin graft there, so it might last longer.
Understood. Well, thank you very much for a great presentation.
Thank you.
Our next speaker is Metha, coming us from Singapore, of course, who will be speaking on presbyopia management in eyes with irregular corneas.
Great. Thank you, Tony. Great. So good morning, everyone. So thank you for coming to the session. So I want to thank the Cornea Society for this kind invitation to talk in the symposium. So I'll be talking about presbyopic management in eyes with irregular cornea. These are my disclosures. It's probably pertaining to BNL, who've now taken over this lens itself. So of course, we know there's an increased desire for patients to be spectacle independent, so many of us to use multifocal intraocular lenses implantation, but they can be associated with certain problems such as phototic phenomena, fixed focal changes, and of course, these are really not suitable in eyes with basically aberrated corneas, and I think most of us will probably feel that in complex corneas, i.e. those who've had previous corneal refractive surgery or corneal scars, we certainly probably wouldn't put a multifocal IOL in. Of course, the range of dysphotopsia with different multifocal lenses varies. I mean, my go-to lens now is a refractive multifocal lens, but even in the refractive lenses, if you put them in these post-cap LASIK patients, you'll see they do have higher rates of basic glare and halos. And of course, in most diffractive multifocal lenses, of course, these levels are basically much higher anyway. So, of course, monovision is an option to basically fix this, but the problem with monovision is that basically you're going to have a fixed focal length either at near or basically intermediate vision. Amma basically describes this pinhole pupiloplasty as a technique to basically reduce aberrations, but of course when you do that, there's no basically view of the retina itself. And we have to bear in mind that biometry accuracy is obviously less in these eyes with basically aberrated corneas. And I just want to illustrate this from basically these defocus curves. So if you look at this defocus curves for one eye that's basically been set for far, and then you look at one eye that's basically set for intermediate or basically near vision, what you have is this sort of valley of depth between the far and near vision. And patients say, well, I can see far, and somewhere they lose it a little bit, and then they can basically see near. And this is what probably I was doing maybe about 6 or 7 years ago for most of my patients when they used to come to try to give them some level of near reading vision after they had post-refractive surgery. So, of course, we need an alternative lens that can basically bridge this gap between in this valley of depth. And the ICA, basically, which is a small aperture implant, was basically developed for this. It gives you a continuous depth of focus with a tolerance up to about 1.5 diopters of astigmatism. You can basically reduce the effect of high-wide aberrations, which is great because I think that's what I use for a lot of my post-refractive patients. Recently, it was approved in the FDA, and we were part of the FDA's data that was used to basically get FDA approval. And I've been using this lens for about 7 years, so I have quite a reasonable experience with this lens as well. This is the principle of the lens. Basically, it's quite simple. It has a mask on the central part of a hydrophobic lens. So it basically will only look at the light rays from the central 1.3 millimeters, and the rays around there are basically masked from the surface. And if you compare the defocus curves in normal eyes, you will see that you get a basically shift of about 2 diopters of extended depth of focus from a standard basically monofocal. The other big advantage of the lens is when you look at MTF function for the quality of the vision measured on the retinal surface, you'll see you have a far better quality of vision of this lens compared to any of the diffractive EDOF lenses or even the non-diffractive EDOF lenses, because of course you get better light transmission, because at the end of the day, the central 1.3 millimeters is a standard monofocal hydrophobic lens. When you look at basically the effectiveness of the lens itself with respect to distance and intermediate vision, looking at the monocular eye itself, the lens works best if you basically aim for a biometry between 0.5 to basically -1 diopter. And what I could typically choose is, if a slightly older patient, I sort of err on the side of caution on about 0.75, -0.75. If it's slightly younger, I basically go on a 0.5 diopter. But remember, this is monocular. But when you see this binocular, patients obviously get very good visual acuity because you have the distance vision from basically the dominant eye. The insertion of the lens is quite straightforward. I do this with flax, and I'll show you a reason why, but actually you can do this with a normal manual well-centered rexus. There's no need to use a femtosecond laser. And in our study, we basically looked at the effects basically in aberrated corneas, and these were basically primary aberrated corneas, such as cases with basically keratoconus, which I think this works really well in, or it can basically be secondary aberrations related to post-refractive surgery, ectasia or corneal scars, or basically related to any corneal refractive basically surgery. So once the phaco is done in the normal manner, I'll just skip this for the interest of time. The lens insertion is quite straightforward. The lens does come in a cartridge. It comes in a 3.2 millimeter cartridge, which I actually never use, which is provided by the company. And all I use an SA60 cartridge, or you can use a J&J cartridge instead. And the lens actually fits in quite comfortably into those cartridges as well, and it will allow you to put it through a 2.6 millimeter incision. You need to be a little bit careful when you take the lens out of the hole. It's quite sticky sometimes and stuff, so I normally go there at the optic-haptic junction. So the lens itself basically just folded into the cartridge. You don't have any issues with the cartridge. You can use a B or basically a C cartridge. Obviously, if you're using a slightly more higher power lens, the lens goes up to 30 diopter power currently at the moment, and the size of the mask is actually fixed, but this may change in the future since B&L now have taken over the company, and they plan to make different options with respect to the mask sizing. So it's 1.3 millimeters in the middle and a 3.6 millimeter mask basically around the surface. So these are some of the cases I use the lens in. This is a patient, 75-year-old lady who's a dentist from Malaysia. You can see that she had previous hyperopic LASIK, so high levels of vertical and horizontal coma, but of course low levels of spherical aberration basically in both eyes. The right eye is basically dominant, so the right eye gets a monofocal lens, and I use an SA60 to balance the spherical aberration. The left eye basically put an IC8 in, and she gets pretty reasonable intermediate vision and near vision, so she's reading N5. But the best thing about this lens is they actually get much better distance vision in the eye than you would actually expect. So she's actually 6'9", unaided for distance, and overall she's got very good distance intermediate and basically near vision. The opposite of that basically is LASIK, post-LASIK correction. So this is a guy who had LASIK 10 years ago. Right eye is dominant, so he's got slightly higher levels of spherical aberration in both eyes that you can see in the right and the left eye. The right eye put a monofocal lens now to reduce the spherical aberration, so I use a ZC-BOO lens. The left eye basically put an IC8, and again, much better unaided distance vision than you'd expect, but good intermediate and near vision, and binocularly very happy with 6.7.5. These are some of the other cases. I've used them in corneal scars. So again, high levels of spherical aberration and vertical coma. The left eye basically underwent flax. The right eye was basically still faking. So binocularly, he's very good with N6 intermediate and near, and 6.6 basically unaided for distance. Patients with RK, it works really well in. I still only put it in basically one eye. We can discuss that a little bit at the end. And again, good unaided vision for distance, but also very good intermediate and near vision. And RK, the whole surface is very aberrated, and I think this is a great lens choice to basically put this in. Other cases, including Intraocular as well, which ironically was also made by B&L, and you can get secondary ectasias. You can see the scarring there basically on the surface. So the aberrations are very irregular on the surface. And again, the right eye, which is the dominant eye, I put a ZC-BOO, and the left eye, I used this lens to give very good intermediate and near vision and best corrected vision as well. So if you look at the defocus curves, the differences, and this is one of the patients from the study, you'll see the right eye now basically you bang on target because obviously it's your dominant eye. The left eye is the eye basically that has the IC8 in. And what you're doing is when you're looking binocularly, you basically bridge that gap. So you don't get that value of depth that you see basically if you go for standard basically monovision. If you look in our series that was basically published in JRS, you'll see most of the cases either post-refractive surgery, which is the cases where I really use a lot of this lens in, and keratoconus. And if you look at the IC8 eye with respect to the fellow eye, of course, the unaided distance vision is slightly worse, but you have better intermediate and also near vision. But but of course it's important to look at the binocular vision, and you can see excellent binocular vision unaided for distance intermediate and near. Likewise, when you look at the spherical equivalent, you'll see that the ICA eye is slightly more myopic compared to the fellow eye. In our paper, we looked at centration values, and that's why I basically use flax. But to be frank, as long as you've got a well-centered rexus, you can just do this manually as well. You don't need to use a femtosecond laser, but you can show from the results that you get very little displacement intraoperatively versus basically postoperatively. When you look at the defocus curves, again, it shows you the same thing from the whole series of patients. Again, you see that effect regardless of the pathology. And when you look at contrast sensitivity, you'll see that, of course, there is a reduction in contrast sensitivity in the eye that has the mask, but binocularly, the patients actually see very well overall, and the function is basically taken from the dominant eye, not the eye that basically has the ICA. So in conclusion, the combination of small aperture optics enabled improvement in near, intermediate, and basic distance vision. Complications in the series, we didn't have any, but I have had to do one lens exchange for a patient who just really couldn't adapt to the reduction in the contrast in her eye. We've had no issues with the procedure. The lens is very easy to insert, but you have to remember about treating the ocular surface after this procedure as well, because of course many of these patients have very irregular corneas, and of course the refractive change in the ocular surface is going to affect the total refractive outcome. Just a few tips: if you do use in younger patients, you may need to give them pilocarpine, because sometimes the pupil dilator will go beyond the area of the mask, and they'll get issues with glare and halos. Some of my patients, if they're younger, they do use this once or twice a week to basically bring the pupil down. I don't do bilateral implantation. Bobby does have a paper on this because of really a reduction in the contrast. You need to be careful with your centration, especially if you're doing it at high levels of keratoconus as well, and patients with larger angle kappas. And if the patients have had ectasia previously and they're cross-linked and they develop haze, you need to be careful, because if the lens centers where the haze is, it will definitely affect the visual acuity. I do YAG them early, but you have to be careful when you do YAG. I go around the mask, and like in the picture on the right-hand side, if they do move and you do hit the mask, you will basically decolorize the mask itself. It doesn't seem to affect the visual quality. It just doesn't look very good as well. And I do combine it, like with Tony's case, with DMEC as well, because it allows you to give a slightly larger landing pad, especially if the patients want to have some intermediate and near vision. Thank you for your attention.
Are there any questions from the audience? I don't personally have experience with IC8, but I had a patient recently, Judd, who was post-RK patient with cataract, and was asking my colleagues about IOL formulas, et cetera, and one of them said that this is their go-to lens in patients post-RK. Yeah. Can you comment, is that the case for you? And if not, what criteria do you go by to decide in a post-RK patient whether this would be the right lens for them?
Yeah, so it is my go-to lens, but the decision that is made is that which eye do you put the lens in, because currently at the moment the masks are the same size. So what I do is that I will look at the basic topography and see which eye has got the more irregular cornea, and that's the eye I basically go for. I basically put the IC8 in, and then the other eye I just actually use a monofocal in itself, and that seems to basically work quite well. But because you've got that depth of focus with the pinhole optics, it allows you to be a little bit more, gives you a little bit more leeway with the accurate and the barmetry form, because that can be obviously very challenging, especially as we mentioned in the regular corneas, to actually calculate an accurate barmetry.
And if the patient is wearing a contact lens or not, does that factor in any way in terms of whether you consider this lens and if you still put it in the eye with a greater corneal irregularity? Yeah,
so most of the RK patients, if they're unaided, then of course, there's not an issue. If they're wearing contact lens, and so if it's a keratoconic, for example, they're wearing basically a contact lens, then I'm slightly more different in that way. If they want more depth of focus, then I would still basically put an ICA, but I'll be much more accurate with the barmetry, because I can aim for slightly more myopic outcome and stuff as well.
Okay. Are there any other questions from the audience?
I mean, Audrey's had experience. She's going to talk on with lens as well, right? So
yeah, Audrey's I think going to speak on it. So maybe we could combine the questions.
Well, a nice transition then to Dr. Sonal Tully coming to us. She's, of course, the chair at the University of Florida. She'll be speaking today on intraocular lens management in PK surgery.
Thank you, Tony, for the invitation to speak here today. And again, when I started doing PKs, it was, we'd take the cataract out, put a lens in, and it didn't matter what it was. People were happy because we were doing it for patients who really couldn't see. And now the expectations with PKs have changed, just like they have for DMEX and DSEC, and everybody wants to be 20/20 uncorrected. So this becomes even, has become a problem even with patients that we didn't used to have problems. So what's the problem? When we have PK surgery, There is issues with post-PK cataract surgery, figuring out the IOL calculations. And when you do a combined surgery, which again, in my practice, we do several of, just because our patients come from so far away, they can't really stage these. Ideally, you want to do the PK first and then do the cataract after you've removed all the sutures. One of the problems, again, with PKs, just like other corneal transplant surgeries, is trying to figure out this whole relationship between anterior and posterior curvatures. They all change even with PKs because you have the sutures, there's higher order aberrations, and sometimes some of the assumptions you make when you measure corneas using placido-based measurements aren't very accurate. And with PKs, sometimes even using Steinflug is not as accurate because you've got multifocal corneas. And then what do you do with patients who've got high levels of astigmatism following a PK? And then we'll talk about combined PKs. So when you have an irregular astigmatism patient, these are patients that I often actually am pretty relieved about because I tell them, you really can't not get away without wearing contact lenses. Once they're going to wear a contact lens after the cataract surgery, the risk, I relax a lot, right? Because I can't really go too far wrong because whatever I do, my optometrist can fix with a contact lens afterwards and they'll be happy. So I don't tell them to stop their contact lens use before I do my measurements because they're dependent on their contact lenses and they're very unhappy about stopping those even for a short while. So I will take them out, but then I tell them, it might be off a little bit, but that much is probably not an issue because you're going to go back to contacts afterwards. We talked about this yesterday. When I do a cataract surgery, every patient that walks into my office at least says, oh yes, I want 20/20 at distance. And you have to temper these expectations, tell them, you're never going to see 20/20 without your contacts. I will get you 20/20 with your contacts if the cornea is clear and everything else looks good. But the only thing you need to see without your contact is your contact. So you need to be minus 250 so that you can see that contact to put it in your eye. If you drop that in your drain and you are corrected for distance, you wouldn't be able to find that contact. So you want to make sure that they understand that you're going to correct them for near. That also gives you a little bit of leeway because if they end up a little bit closer, a little bit further away, they still have useful-ish vision at some distance. If they're irregular, you can still attempt corneal things that you can try to do to decrease the amount of astigmatism they have. So if you can see that they're irregular but mostly regular and mostly have astigmatism in one direction, you can do relaxing incisions. You can put compression sutures in the opposite direction because even with that, when you put a contact lens, you can get rid of all the errors. But you do not absolutely want to put a toric lens in these patients. And they will need contact lens refitting after the surgery because you are changing the intraocular lens power that they have. The regular astigmatism patients become a lot more complex with PK surgery because these patients do want to be able to get rid of their contact lenses. If they plan to wear the contact lenses, then again, you can relax, you do the same thing as you do with an irregular cornea. But if they don't want to wear a contact lens, now the discussion becomes a lot more significant and you have to have them remove those contact lenses for a while. And I say about a month, but oftentimes if you see that they're warped, you do a topography and their warpage hasn't completely resolved, you might need to wait 2 months or 3 months to let their corneas completely relax. And a lot of these patients who've been wearing things like rose K lenses or other RGP lenses, their corneas can take a long time to get unwarped. And so you want them to be out of those contacts before you do the measurements. Now again, corneal relaxing incisions, compression sutures are usually not an issue because you can do those. If you put a toric lens, you better be very, very sure that they are not going to go back to a contact lens after surgery. Because you put a toric lens in and they put a contact lens on top, now you've gotten the opposite of their initial astigmatism and they will be very unhappy. And then, do you correct them for distance versus a little bit myopia? I still try to adjust them for a little bit of myopia. I tell them the advantages of being able to, and a lot of people who've had PKs for keratoconus, for example, several years ago, they know what it's like to have myopia and not have that. And they are often not very unhappy about having near vision. And that, again, gives you a little bit of wiggle room because they can always move things if you're not right on the mark. We saw some of the talks about how do you do measurements in irregular corneas, and a lot of these apply to the PK, so I won't reiterate those. But you do want to maybe give yourself a little bit of wiggle room when you're doing these surgeries, because they don't always end up right. When you're using a toric lens, again, make sure they don't want to wear contact lenses. Make sure the astigmatism is very, very regular. Now, again, a lot of these patients are used to not having great vision if they don't wear contact lenses, and they're just happy not to have to put their glasses on first thing in the morning, and they're willing to put up with a little bit of irregularity or not perfect vision. And sometimes that gives them a multifocal cornea, so they actually like that because they can see different distances, like our keratoconic patients, from different parts of their cornea. So I'm a little bit more flexible with the amount of astigmatism that's regular versus irregular. And then make sure your astigmatism aligns with different instruments. If you're getting them different in different instruments, then do not put a toric lens in. And again, make sure all their sutures are out before you do this. I've had patients 20 years from PK surgery that my partner did, and they broke a suture and flipped 10 diopters in the opposite direction. So you want to make sure that if you're going to put a toric lens, you better be sure they're not going to change. And we used to tell people you can't get a toric lens if you are young because you might need another transplant. Now we don't typically do PKs for PK failures. We do endothelial keratoplasty, which is more forgiving. So here's an example. I think I showed that to some people yesterday, so ignore me if you've already heard this, but this was a patient that I used intraocular aberrometry, PK for a fungal ulcer, did really well except 10 diopters of astigmatism, no sutures in the direction of astigmatism. All their sutures were out. I couldn't get any measurements, but it was pretty regular. So we did intraocular. I put a toric lens in, and the astigmatism went from 10 to about 6. We then put in some relaxing incisions, and the astigmatism went down to 4 diopters. I then put compression sutures, and I flipped them from against the rule to 4 diopters with the rule. So I took a couple of sutures out, and they were then down to 1.5 to 2 diopters of astigmatism with the rule, which I thought was a pretty good outcome. She was thrilled. The other eye had RK2 and was hyperopic. She was matched up. She was 20/20 with small prescription for glasses and very happy with this. Even though it wasn't perfectly regular, she still got a pretty good outcome. What about when you do cataract and PK together? Well, now you're going to use their corneal keratometry, right? Because you're going to take their cornea off and throw it away. And so using their keratometry does no good at all. So I usually look at what my outcomes are from my last 100 transplants and where I sort of ended up. And so I tell my tech, use a 46K because that's where I sort of end up, and I usually plan for a little bit myopia. And so, when you do these surgeries, you know that you're not going to get the suture removal becomes very critical afterwards. Now, this patient, obviously, coming from a long distance, we don't know what to expect in there. So we're planning to do a triple so that they don't have to have another surgery. My fellow is trying to do a capsulorhexis, but remember, again, with these patients, you don't have a flat anterior chamber or flat anterior capsule, and so they tend to run out. So he did run out, and you can always switch to a can opener. And the reason I like to do these triples is it's so much fun to remove that lens. It's like delivering a baby, and it's and you get this lens that you can show patients. Oh, look, this is what I took out of your eye, and so those are kind of fun to do, which is probably why I do some PK triples. And then I always put a 3-piece lens in these patients because you never know, especially if you've done a can opener, whether you're going to be in the bag or outside the bag. And these are a lot more forgiving if they go into the wrong place. And then you do a transplant just like you normally do. Remember, your corneas are going to end up steeper, so which is why I use my last few transplant outcomes. And then your axial length is longer, as we talked about with keratoconus too, but the axial length elongation is usually because the anterior chamber is bigger, and so your lens is further away. So that sort of compensates each other out. But remember, your corneas are going to be steeper, so don't use the other eye, for example. And some final thoughts. We've heard about light adjustable lenses. We've heard about small aperture lenses, and those are good options for these patients because especially in those irregular corneas, the small aperture lenses, and you'll hear another talk on that. You might need to do postoperative refractive surgery, and I've done LASIK on patients or PRK on patients who've had PKs, and you can do them. They're a little bit more challenging, but you might need to do that if you have a refractive surprise or postoperative suture breakage. And then whenever you're in doubt, aim for near. You can only, as long as you can give them useful vision at some distance, they're usually pretty happy about this. Thank you.
Okay, we have microphones in the audience for anybody who has questions. I have one or two, actually, if there's time. First is on corneal relaxing incisions. We developed a nomogram together. David Rootman and Sonia Yu and David Wong did the mathematics of femtosecond laser-assisted AK in patients after PK. And we found there actually can be a shift to the spherical equivalent in a fairly significant number of patients. So you do your AK incisions in the graph, the average K value goes from 44 to 46, let's say. So that gets to my question. Do you typically do corneal relaxing incisions at the time of cataract surgery, or do you do it before or after?
That's a great question. I typically do them at the time of cataract surgery, and again, because of my patient population.
The post-PK patients.
The post-PK patients, yeah. So I do them at the time of cataract surgery, and I do usually combine them with corneal compression sutures because I find that, at least the ones I'm doing these on, the amount of astigmatism they have does not meet your nomogram, or does not completely get corrected by your nomogram. And I always over-correct with the sutures, and that way you can always take them out. So I use my sutures as sort of the adjustment. I do and I find that the relaxing incision effect does tend to decline over time. So I do the relaxing incisions following the nomogram. Or sometimes what I'll do is I'll actually just rip the graft host junction in that axis rather than actually doing the AKs within the graft. Gives you a little more oomph if you're doing it closer to the visual axis, a little bit less in the axis, but then I'm not creating yet another weak area on their cornea. And then I use overcorrection with compression sutures to compensate for that. And with that combination of the two, I find that their spherical equivalent pretty much ends up being where I planned it with the IOL.
And then the second question, you mentioned that torics are an option for patients with keratoconus who have a PK for keratoconus, let's say, because if the endothelium fails, you're going to be doing endothelial keratoplasty. But I think we've all seen these keratoconic patients, though, who over decades tend to get that thinning at the inferior graft host junction and that anterior protrusion. So I've had the displeasure of doing a fair number of PKs because I had to do a PK on a keratoconic patient because of that sort of ectasia at the inferior graft host junction. And these are folks, many of them with torics in, right, which then becomes problematic. So do you have any suggestions for those in the audience who are thinking about putting a toric in a keratoconic? Is there an age cutoff? Is there things you look for in an exam to look at and say, is this person going to become one of those who's going to get that inferior ectasia and therefore may not be a good candidate for a toric IOL?
Yeah, no, that's a great thought. And now, again, I see those ectasias in the graphs early on after their PKs. So typically when they're in their 60s or 70s and they're getting cataract surgery, if they haven't had that ectasia at that point, they're unlikely to have it. So in those patients, I'm very comfortable doing that. If I have a young patient who, for whatever reason, got a cataract and they need that, then I do not do a toric lens in those patients because I do expect them to change over time.
Right.
But once they're past the age of about 40, I'm a little bit comfortable doing things because I figured they would not get that thinning if they haven't had it at that point. If they have had some, then I'm a little more careful.
Right. Okay. Yes, we have a question here. Yes, sir.
Great talk. I am
Thank
Yamaguchi
you.
from Tokyo Dental College, Japan. I have 3 questions. When you perform a triple procedure, what kind of IOL calculator formula do you use? This is the first question. And the second
What
one
kind of IOL do I use?
IOL formula.
We have time for maybe one or two
calculation
questions
formula.
with one more speaker.
SRK or high G.
Oh, formula that I use. Oh, gotcha. I typically use the SRKT formula.
SRK. And second question is, when do you remove sutures? I think removing suture induces a myopic six about the 3 diopter. How do you think of?
Yeah, so when I do the PKP triples, my corneas do not end up at 46 when I finish the surgery. So they're much flatter. I estimate that they're going to keep steepening up to 46 after I remove the sutures, which is why I use the 46
I see.
Cornea.
That's the third question for me. So you put the K value of 46 diopter.
Right, based on what my previous ones ended up.
Thank you.
Thank you.
Thank you very much for your questions. Our last speaker is Dr. Audrey Rostov, who will be speaking to us on small aperture intraocular lenses for complex corneas.
Thank you, and thank you for inviting me. I will be continuing where Joe left off. My financial disclosures, I am a consultant with Bausch & Lomb. We've already been through the small aperture optics and what the lens looks like with that filter zone there, so I will just go through there. Complex case selection, it is my go-to lens. The small aperture lens is my go-to for RK, and I actually do use it bilaterally in patients, not just unilaterally. Also select case of corneal scars as well as for keratoconus. First case is a 64-year-old woman who had a 16-cut RK. Here is her pentacam, as you can see here, with the flattening and the higher order aberrations, and this is her refraction. This is her left eye. Every single patient I do cataract surgery on, whether they're a premium IOL or irregular cornea or whatever it is, I do get an OCT of the retina. And even though I'm not a retinal specialist, I could tell you that the MAC OCT of the right eye is abnormal and there is a lamellar hole there. That's about the extent of my retina knowledge. Diagnostics, when we get biometry, I aim for about a -1 to -1.25 for post-RK patients. This is with a small aperture lens and also for corneal scars. For keratoconus, I do a little bit more myopia in the -150 to -2 range. I always get tomography and again the OCT of the macula. I really want to temper patient expectations and emphasize that the pre-existing pathology will ultimately limit their visual acuity, and the goal is to improve but not perfect. For this patient with the 16-cut RK, the right eye, I chose a toric lens because of that macular pathology. And you could see here, actually, that I used scleral incisions because of the multi-cut RK. Scleral incision, I'm still doing my biaxial cataract surgery, but scleral incision is going to be better than going through where you have your RK incisions. For the left eye in this patient, I chose the small aperture IOL. You could see what the post-op photo looks like, and she did quite well. Case 2, we have an RK patient, a 74-year-old gentleman with 10-cut RK this time. And here you could see this is the surgery. I measured and saw that actually I could, in fact, go ahead and get the keratome in between the incisions, and so chose to go through clear cornea. Again, I do biaxial surgery. There's the cleanup. I like what Joe suggested about doing the other IOL cartridge. I've just been using what Bausch & Lomb supplies. It is very, very slow unfolding. You need a 3.2 incision, and so you do need a slightly larger incision there. It unfolds slowly, and the main thing is that after it's unfolded and you manipulate the lens, you need to avoid that filter zone. That is that dark area that gives the pinhole optics. So you actually need to be sure that you are avoiding the pinhole zone. Surgical technique, a few pearls here. I have a very low threshold for placing sutures in the cornea, in the incision, whether it's scleral or it's a clear corneal incision. If the corneal scar or keratoconus patient, clear corneal incisions are fine. You have to measure if you're doing an RK patient, and again, avoid the filter zone. This patient's post-op vision with a 10-cut RK was 20/25, and that's uncorrected. Another case, 56-year-old with a corneal scar, and again, you could see the irregular tomography there, the irregular astigmatism, and here are some results. For his right eye, which was his unaffected eye, I chose an EDOF lens. I think I put a Vivity lens in there, and you could see that there was definite improvement in both post-op for both the EDOF, the normal right eye, as well as for the small aperture IOL. Again, for this patient, I chose slightly more myopia and also wanted to emphasize that the goal is to improve but not perfect. Lastly, we have a 67-year-old woman with keratoconus, as we've been discussing, and here's her tomography. This was her pre- and post-op vision. And again, I went for more myopia. As Sonal discussed, we like more myopia for these keratoconus patients. They're used to being myopes, and so therefore you want to leave them with some myopia as well. Patients with PK, post-PK, I'm a big toric IOL user in post-PK patients, and I do femtosecond laser relaxing incisions at about 7 millimeters at the time of the surgery and find that there's a synergistic effect. You can also use a pinhole lens here. I have not done that yet, tend to use the toric lenses and such. Post-operative considerations, again, Jode went through how you do the YAG. You want to avoid that filter zone. There's special online training that you need to take, and I absolutely recommend it. For RK, again, small aperture lenses, it's my go-to. For corneal scars, you can also consider it. And for keratoconus, if there is not significant displacement of the cone and there's no significant apical scarring, you need to look at that topography and tomography and look at the astigmatism. Then you can also have success here as well. Again, sutures may be required, especially in those RK patients. If you're using flax with RK, you need to be careful about your capsulotomy removal because of the discontinuities that there can be in the capsule. However, it is still quite easy to remove. And in summary, all patients deserve the opportunity to optimize their vision, even if they have corneal pathology. Thank you.
Thank you very much for a great presentation. Again, any questions from the audience, please come to the microphones. And I'll ask those who are here for the next session to please keep our voices down to allow us to finish this session undisturbed. Thank you.
Thanks. Thanks, Audrey. That was awesome. My question is sort of post-operatively, fundus examinations and what if they need retina surgery? Is that a big deal when you have the small aperture lens?
As long as they dilate well, the answer is no. And I discussed this with some retina colleagues. You have to make sure the patient can dilate well. If they cannot,
so they can see it from beyond.
Exactly. Yeah. If they don't dilate well, or there's any concerns, like if they have macular pathology preoperatively, that case I showed, then I'm not going to put one of these in. However, if they have a normal macula, they dilate well, then I don't think it's an issue.
I have a question. You mentioned a couple of times avoiding the filter zone, like during implantation. What happens? Why is that?
You can damage it and you can scratch it. And I guess theoretically, one of two things. One, you can damage the lens, but also potentially that pigment, you don't want to release that pigment.
So it's actually pigment impregnation on the surface of the optic.
Correct.
Because you mentioned avoid it during the YAG, but then you mentioned also avoid it touching it during the implantation,
yes,
et cetera. Okay. It'll come off.
Yeah, it will come off. So you need to avoid it, as Jode said, both during the YAG as well as be careful of it. Don't touch your instruments to it during implantation or during your IA.
Okay, good tips. Any other questions for the speakers? If not, then we will conclude this session on intraocular lens management for corneal specialists. Some of the speakers may be available for questions you may have just outside the room. And I want to thank everybody very much for coming to the session.